Welcome to our channel Medicine A to Z. Today we are going to discuss about hospital-acquired pneumonia. Definition. Hospital-acquired pneumonia is pneumonia that occurs 48 hours or more after admission to the hospital. Epidemiology. One of the most common and morbid hospital-acquired infections. Risk of hospital-acquired pneumonia is approximately 10-fold higher in ventilated patients compared to non-ventilated patients. Most cases occur in non-ventilated patients due to their greater numbers. Pathogenesis. Primary route of infection. Microaspiration of organisms colonizing the oropharyngeal tract, less commonly, the gastrointestinal tract. Hospitalized patients often become colonized with microorganisms acquired from the hospital environment, and as many as 75% of severely ill patients will be colonized within 48 hours. Common organisms include Staphylococcus aureus, including MRSA, and Pseudomonas aeruginosa. Other common pathogens you should be aware of are aerobic gram-negative bacilli, such as Escherichia coli, Klebsiella pneumoniae, Enterobacter species, Acinetobacter species, and gram-positive cocci, for example, Streptococcus species. The prevalence of pathogens in ventilator-associated pneumonia, or VAP, based on CDC data from 2015 to 2017. The distribution of VAP pathogens is as follows: Staphylococcus aureus, 28.8%, Pseudomonas aeruginosa, 12.9% Klebsiella species, 10.1% Enterobacter species, 8.4% Haemophilus influenzae, 5.9% Streptococcus, 5.7% Escherichia coli, 5.6% Acinetobacter, Baumannii, 3.2%. MDR bacteria are most common in patients who have been hospitalized for prolonged periods, specifically 5 days or more. They are also prevalent in patients who have received antibiotics within the preceding 90 days. Recognizing the risk factors for MDR bacteria can help in taking appropriate preventive measures and ensuring effective treatment plans. Risk factors for MDR pathogens. Intravenous IV antibiotic use within the previous 90 days. Septic shock at the time of VAP acute respiratory distress syndrome preceding VAP. More than 5 days of hospitalization prior to the occurrence of VAP acute renal replacement therapy, prior to VAP onset. Let's discuss the timing of antibiotics for non-ventilator hospital-acquired pneumonia, or NVHAP, and ventilator-associated pneumonia, or VAP. When NVHAP or VAP is clinically suspected, it is crucial to obtain microbiological specimens as soon as possible. Early sample collection helps in accurate diagnosis and targeted treatment. For patients showing signs of septic shock or rapidly progressive organ dysfunction, start antimicrobial therapy immediately. Prompt treatment is essential to improve outcomes and reduce complications. When choosing an empiric antibiotic regimen, consider these key factors: local distribution of pathogens and their antimicrobial susceptibility patterns. The patient's risk factors for multi-drug resistance, such as recent antibiotic therapy, opt for a different class. Prior microbiology data. Note any colonization or previous MDR pathogens. Potential adverse effects and drug interactions. The patient's severity of illness. For severe illness like septic shock, use immediate active antibiotics. For less severe cases, a narrower regimen with close monitoring may be sufficient. Drug cost and availability. The clinician's familiarity with different antibiotics. For initial antibiotic therapy, all empiric regimens for VAP and NVHAP should include agents effective against Staphylococcus aureus, Pseudomonas aeruginosa, and other gram-negative bacilli, for empiric regimens when there is no suspicion of multi-drug resistance. Piperacillin-tazobactam, 4.5 grams IV every 6 hours, or cefepime, 2 grams IV every 8 hours. An alternative option is levofloxacin, 750 milligrams IV daily. This is preferred if there's a high suspicion of Legionella infection and should be used if local resistance rates to fluoroquinolones are low. If MDR gram-negative bacilli are suspected, the preferred empiric antibiotic regimens are meropenem, 1 gram IV every 8 hours, or imipenem, 500 milligrams, IV every 6 hours. Choose meropenem or imipenem for patients with risk factors for MDR or ESBL gram-negative bacilli and no history of carbapenem-resistant pathogens. Monitor closely for seizure risks associated with imipenem. If you suspect carbapenem-resistant pathogens. Among the arsenal are potent combinations like ceftazidime, avibactam, administered at 2.5 grams intravenously every 8 hours. Ceftolozane-tazobactam, another formidable option, is prescribed at 3 grams intravenously every 8 hours. For effective treatment, imipenem-cilastatin-relebactam is administered at 1.5 grams intravenously every 6 hours. And meropenem-vaborbactam, a crucial ally in this fight, is prescribed at 4 grams every 8 hours. Alternative options. Aminoglycosides like tobramycin, dosed at 5 to 7 milligrams per kilogram intravenously daily, though caution is advised due to limited lung penetration and potential toxicity. Polymyxins such as colistin, administered with a 300 milligram loading dose followed by 150 milligrams every 12 hours, are reserved for the most resistant infections, despite the risk of nephrotoxicity. Aztreonam, at 2 grams intravenously every 8 hours, serves as a reliable second agent when paired with another beta-lactam. And don't forget the anti-pseudomonal fluoroquinolones, with options like levofloxacin at 750 milligrams daily, or ciprofloxacin at 750 milligrams intravenously every 12 hours, or 400 milligrams orally every 8 hours. If you suspect MRSA linezolid, 600 mg IV every 12 hours, oral administration possible when patient can take oral medications. Vancomycin, dosing as per vancomycin dosing guidelines. Linezolid preferred, limited IV access, difficulty achieving therapeutic vancomycin levels. Vancomycin preferred, patients on SSRIs. Patients with cytopenias. Alternative agents. Ceftaroline, 600 mg IV every 12 hours. Tedazolid, 200 mg IV once daily. Oral administration possible when patient can take oral medications. Telavancin, 10 mg Colig IV every 24 hours. Consider boxed warnings. Ceftobiprole, 500 mg IV every 8 hours, for NV-SHAP only. Clindamycin, use only if local antibiogram shows high susceptibility of MRSA isolates. Stay updated with the latest in medicine. Subscribe to our channel for comprehensive videos covering the latest updates in the field.